Today, I have the absolute honor of introducing someone who has dedicated her career to advancing endocrine and pituitary care around the world, Dr. Christine Yedinak. Christine completed her education at the University of Southern Queensland in Australia and Oregon Health and Science University, where she also earned her master's degree, family nurse practitioner certificate, and doctorate of nursing practice. For over 20 years, she provided specialized care to pituitary patients at Oregon Health and Science University's Northwest Pituitary Center. She is the immediate past president of the Endocrine Nurses Society and the Federation of International Nurses in Endocrinology. She serves in leadership roles with the American Association of Clinical Endocrinology and continues to shape endocrine care through research, international presentations, and clinical guidelines. Chris has dedicated her career to improving outcomes for patients with pituitary and adrenal disorders. Chris, I am grateful that you have joined me today. Welcome to Talking Acromegaly with Tony.
Well, thank you, Tony. I'm very pleased to be here. Thank you for the invitation.
The pleasure is all mine. We'll get right into it. So let's go right from the top. What drew you into endocrinology and pituitary care?
Actually, it was an interesting introduction because I had been developing a standalone surgical center, and I got interested in project development. And there was an opportunity at OHSU to develop a pituitary center, and that kind of intrigued me. And so I had some background in pituitary care, but really when I started working in this environment, I discovered how much more I needed. So that kind of drove me further towards my studies and some academic preparation.
Sounds good. For people watching, what does a doctor of nursing practice bring to patient care that might be different from other providers?
I think one of the things we do just as nurse practitioners is bring in some of the overall quality of care issues and quality of life issues that patients experience. But moreover, I think we look at the patient in the context of their particular environment, their family environment, what it is that they need, what they understand, where are they at within in their disease process, and how can we help them to adjust further to living with whatever that disease process happens to be. So I think it's a little different in every state as well. So
So it seems like you kind of focus on better quality of life.
very much so, and look at prevention. So how can we prevent further complications from a disease process that somebody happens to be dealing with? So it's looking at them in total context, looking at the person, and very individualized in its approach.
Everyone, as we all know, is different. I started off with an IGF-1 of 1400 the day of my surgery. When you have a patient who comes in with a higher IGF-1, where do you start and what's the focus?
So once we know what the IGF-1 is, by the current guidelines, an IGF-1 that's very elevated like yours, we would immediately say, okay, where is the tumor? Where is this a tumor that requires immediate removal? And that's often the first choice is surgery. Let's see if we can remove as much as possible. Usually a bigger tumor, a bigger or higher level may mean a bigger tumor. And so we have to really take that into account. But I think, first of all, when I see somebody with a level that's that high, my concern is how long has it been that high, and what potential issues could there be associated with that? This person has probably been living with that. But it's not only the person, right? It's the family of that person, their contacts that have been living with this disease. So there's a whole adjustment that needs to occur for everybody.
I'm glad you mentioned that because actually, not only do I live with acromegaly, my wife and my three sons have had to as well. I'm very thankful for the patience and grace that my wife has provided me over the years and the care that she's given me through my acromegaly. Do you
Absolutely.
find that other patients with acromegaly have been able to have the patience and grace that I've been able to get from my family?
It varies very much so. I think it's a difficult thing for families sometimes to understand because what I hear is this isn't the person that I married, for example. This isn't the relationship the way it was started. And I think it really depends. Certainly, there's also some concern from siblings, for example. Do I have this disease? Is this something that I really need to be concerned about? So I think not everybody has the same support. It does affect families very negatively sometimes. And so sometimes it's helping the family to adjust to those kinds of issues. And we're counselors, I guess, as well as practitioners in the sense that the disease is just not a number. It's just not an IGF-1. The disease is very composite to a lot of emotional issues, a lot of family issues, a lot of support issues, a lot of what do I do now type issues, right? Where am I going? So it's not an easy one size fits all. So it's great to see if we can help people through that to understand in a family context what's going on. So the family should really be involved in that whole process of diagnosis and treatment.
Yes, and I started this channel, my advocacy, based on how I felt. I wanted to give people the support that I didn't have. I think having conversations with medical professionals like you, I'm able to extend that support system that I didn't have. What are you doing as far as do you recommend therapy? Do you have the conversations yourself? Or exactly how are you doing it to help patients deal with their acromegaly?
I think all of the above. To begin with, I think one of the important thing is, yes, you bring your family with you. Whatever family member is your support system, and they then understand a lot more about what's happening is in that process, in the treatment process. So I think that's one issue. Having the person really understand themselves what's happened, I think, is another important issue because there's so much that's associated with acromegaly, for example, or Cushing's if you're a pituitary patient with Cushing's, and of course a lot of other endocrine diseases. It's not just a single issue. It's not just I can fix this one physiologic change and everything goes away. Um, So, yeah, when I first see somebody, you really have to make a very big evaluation of what are the issues, where is their major support, how can I support that? Do I do counseling? Yes, I think we all do. That's what is part of medicine is still the art of medicine, which is being able to counsel a patient. Do I recommend some patients go for counseling or marriage counseling? Yes. Um,
Okay.
are there a number of counselors that really understand acromegaly? No. And I think that's a problem. That's a limiting factor for a lot of people.
I'm gonna switch gears a little bit. I have an upcoming test, and it's a test that in the beginning I didn't know much about. And I think if you can explain this test, it would help other people. My doctor wants me to take ACTH stimulation test.
Okay.
Can you explain what that is?
So often we'll do an ACTH stimulation test, particularly when a patient first presents, but also we may do it after they've had some kind of treatment like medical therapy or surgical removal of a tumor. What we want to know is whether the adrenal function is normal and whether, in fact, particularly if the patient has symptoms of adrenal insufficiency, whether, in fact, they need medical support to treat adrenal insufficiency, which is replacing glucocorticoids that adrenal glands don't make. So it's a common tests that we do just to evaluate whether the patient has adrenal insufficiency. And so we could do it any time, but often we'll do it immediately post-op if we've got symptoms of a patient having insufficiency. Does that answer the question?
It does. I was diagnosed at one point with secondary adrenal insufficiency. So now I'm at the point where he thinks I could be able to come off of the hydrocortisone. I've had a conversation about that test with other people. I think hearing it from a professional like yourself, it'll help them understand exactly their process. With that being said, let's get into the other numbers, the IGF-1s, the growth hormone levels. For example, my growth hormone level right now is a 0.8. For a patient with that level, what are your thoughts and what would you suggest? I try to use myself as an example for people.
No, I mean, getting it below that 1.0 is really important. So it's 1.0, the upper limit of normal. So we want to see it below the upper limit of normal if we can. The key then is, okay, what's happening with your symptoms? So are your symptoms controlled? Because what we don't want to see is poor symptom control and then ongoing issues with what we call concomitant disorders that are associated with acromegaly. We don't want your bones to be deteriorating, the joints to be deteriorating. We don't want you to have problems with blood glucose and etc. So and heart problems and cardiovascular problems. So we want to make sure that that control is translating to normalization of some of the other factors that are associated with acromegaly.
On the subject of hormones, how do hormone imbalances affect mood, energy, and mental health, in your opinion?
Oh, very much so. When you think about where the pituitary sits, it sits in an area that's right beside what we call the limbic system. And the limbic system is the emotional control kind of regulatory system of the body. And so there's a lot of two-way, the hormones go up and down. It's the hormones are omnipotent, right? They affect most things in the body. And so, that mood changes, and we talked a little bit about brain fog, right? Those kinds of things are very, very common, I think, with disorders in pituitary because, again, it sits right there by the limbic system. And, any kind of mismatch or imbalance can affect that system. And so when we look at a patient to begin with, when a patient comes to a pituitary facility, the first thing we do is we test all their hormones. So once the person is referred, every hormone we want to be able to test to see whether there's a deficiency in any other pituitary hormone. And so then we monitor that over time. So it may be that improves like after a surgery or after treatment, or it may be that it doesn't improve and we need to supplement those hormones.
You talk about brain fog. I quite often talk about brain fog. I suffer from it regularly.
Yep.
What's really happening there? Can you dive into that a little bit more?
I think it's one of the million-dollar questions. It's probably a composite of a lot of factors. It's a factor of the disease. It's a factor of the hormonal imbalances. It's a factor of the fact that you haven't been able to do a lot of the things that you would normally do. It's a factor of diet. It's a factor of exercise. So there's so much that's interwoven, and, people complain about brain fog associated with fatigue, confusion, and, lack of motivation. Just, I can't think straight. I can't find words. So, I think it means something a little bit different to each person. And so when you talk about it, what's the causation? It's a bucket. It's a big bucket.
How do you approach conversations around hormonal deficiency, testosterone, estrogen in pituitary patients?
I think directly, number one. So first of all, I think one of the things that I notice with pituitary dysfunction in males is that testosterone is affected very, very early in the game. And so I think it's difficult sometimes for patients to come in and say, I have a problem with my libido, right? I have a problem with sexual function. And so it's a very common need to ask that question, okay, what's happening with your sexual function? And that, of course, affects relationships back home. And so, that's a normal kind of segue into, okay, how are things with your emotional relationships with your spouse? I think one thing we do is very directly say, okay, what's happening here? And then I'll test. I'll test as a normal part of this process. So if a female comes in, I find out what's happening with their menstrual cycle. I think libido is a lot harder to work with for females than it is for males. So, but that doesn't mean to say that it's not improvable, right?
Okay.
Can we give you back where you were when you were 30? Probably not, right? But maybe there's some assistance so we can give people both emotionally, right? Because libido and sexual function is both an emotional issue and it's a physiologic issue in terms of what's happening, to the pituitary, what's happening with the hormone levels. And so we try to approach each of those things to be able to then work a plan to improve whatever is the biggest concern for the patient.
Let's say, for example, you've gotten a younger patient, 25, 24-year-old female. How could acromegaly possibly affect their fertility?
And it's a very important question. Yes, it can, unfortunately. Sometimes what we see is the patient will present with a high prolactin level. And the high prolactin level for females is preventing them from getting pregnant. And so I think it's a very important issue to talk with that particular patient about is are you wanting fertility? And if that's the case, then we're very conservative about the treatment in effect. I mean, we want to be able to bring down the IGF-1. We want to be able to treat that prolactin and normalize that prolactin. But we also want to make sure that when we do surgery, we're trying to preserve as much of that function as possible, right? So it's a very sparing surgery in the sense that we want to make sure that we can keep that LH and FSH alive and well. So not only that, it may be that if this is a big tumor and it's affecting moving out into other areas beside the pituitary and it's really compressing that pituitary, that means that there's a higher percentage of possibility that this patient will be infertile, and particularly once we remove that. So it may be that we ask them to preserve some eggs so that later on they can be used for fertility if they really wanted fertility. So I think there's discussing those kinds of options and looking at a plan that may be acceptable to the patient.
As far as managing hormone health, is there a role that lifestyle, maybe sleep, and stress and nutrition, does that play a role in it? And if so, how?
I mean, absolutely. I think it plays a role for everybody, right? But we know that just plain exercise is an antidepressant. And so, doing something physical every day, trying to walk the 10,000 steps, I think that's really hard for all of us, right? But trying to get that number of steps up, the exercise, getting good sleep is a challenge sometimes, but it's also, okay, let's reduce the alcohol, right? Particularly before bed. Alcohol doesn't make you sleep. It actually will make you tired to begin with, and then you go to bed and it wakes you up. Oh, I think it's managing the kinds of diet and exercise routine that's going to be most beneficial for you as an individual. And I think, yes, all of those factors will help in terms of hormonal health. We are learning a lot more about the gut and the gut biome and what our diet actually does to that and how that affects your hormonal balance in many ways. So all of those factors, I think, are really important, not only for people with pituitary diseases, but for all of us in general.
I want to switch gears back to IGF-1. I was having a conversation with a person whose IGF-1 has been in range for quite some time. And here recently, her IGF-1 has been creeping up. Is there any reason why your IGF-1 would be in range for so long and just start to creep up or go down?
One of the issues I think that's important is, and I don't think we emphasize it enough, sometimes when you start to get values that are different, number one, they may not be accurate. Okay. Number two, they may not have been done in the same lab with the same type of assay. And so keeping those things very standard and steady is important in being able to evaluate what's happening with that particular IGF-1. The other concern, of course, is this tumor regrowing? And so that, I think, that's where my antennae would start to raise. Okay, so what's happening with your symptomatology? Is that changing? Are you getting more headaches? Any visual changes? So that starts a whole new cascade of questions and inquiry, because my concern is, of course, if this is a trend and it seems to be going up, that in fact this is a tumor that's regrowing and needs to be attended to. So I would want to see on MRI what's happening.
Okay. Okay, Chris, let me ask you this. What does the role of cortisol play for people like myself living with acromegaly, a higher or a lower cortisol, and how does it affect us?
We have a certain level that we need of cortisol every day. So cortisol usually goes up very early in the morning. It gets most of us out of bed. It has more trouble with some of us than others, right? And then during the day, it usually slides off. It might have a little blip every now and again if you have an argument with your spouse or your boss or whatever. Somebody runs a red light, the ACTH and cortisol goes on up, but then it comes back down again. And usually at night, it's very low so we can sleep. It never goes to zero. You need to have cortisol to stay alive. And that's the key. If you do not have enough cortisol, then you're fatigued. Then you're at risk for insufficiency, which means that you can eventually have very poor outcomes from very low cortisol levels that are not sustainable if you have an injury or an illness, and then it makes somebody very susceptible to very poor outcomes. But again, too high, for example, with Cushing's patients, that has lots of implications around the body because it affects the immune system. And so it makes people more vulnerable to illnesses. It affects clotting, and it makes people more vulnerable to having clots, heart attacks, etc., strokes. It also affects bones, so it takes the calcium out of bones. And so bone density and fractures can be a problem. It affects problems with muscles and muscle function. And so people have a lot of muscle wasting and pain. And joint pain. So both ends of the spectrum are not good. You want to be at the Goldilocks measure, right?
Yep.
Just enough, and be able to make it when you need it, and not make it when you don't need it.
I want to talk about endocrinologists for a second. You teach, and you and I touched on this in a conversation that we had. People have a hard time finding endocrinologists who are experienced in acromegaly. Do you find in teaching that you have less people over the years who are going into endocrinology, or is there a leveling off with it? Can you go into detail a little bit about that?
Yeah, unfortunately, it's not something that seems to have this ongoing increase in entry to practice. So there are probably, it depends on whose statistics you look at, but the HRSA published certificates published statistics rather in 2025 to say that there was about 9,500 endocrinologists in the US, which is not a lot of endocrinologists. It really only represents, I think, somewhere between 10% and just over of all specialists, right? So it's a very small number by comparison. And really, when you think about the diseases that they deal with in endocrinology and metabolism, diabetes is probably the biggest problem. So we have about 1 in 8 people in the United States have diabetes. So if you break that down to the number of people based on the number of practicing endocrinologists in the country, that means that those endocrinologists, each endocrinologist is probably seeing about 20 patients a day with diabetes. So there's not a lot of space left, right? And so when you talk about, how well we have coverage, we don't. And some states, in particular for pediatric endocrinologists, do not have a pediatric endocrinologist. So even with that, you have somebody that's diagnosed in a rural area in particular with acromegaly. And again, we're talking about having that expertise available to diagnose that person in the rural area. They may have to travel to another state to be able to find an endocrinologist that actually then focuses on pituitary diseases or acromegaly. So that's one of the reasons why we've got these centers of excellence now around the country, but there's probably only about 15, right? It's maybe very difficult to access for some patients, it's a big problem.
About how many patients do you currently treat with acromegaly?
So, when at last, when I was at OHSU, we were treating over 70 patients and probably well over 100. But again, that's a center of excellence. So I think most people would only see maybe 1, 2 in a practice lifetime. And I want to qualify that because I think what we teach is we teach that, okay, this is the end of what this patient should look like, right? So we have this person that presents that has clearly had acromegaly for some time. And so that's what the textbooks then try to teach is like, this is what a person with acromegaly looks like. But in fact, what we want to do is to be able to identify that patient way, 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 way earlier. When their hands start to grow, right? When their shoe size starts to grow, when we have very subtle changes so that we can prevent long-term a lot of these secondary issues that occur and really disturb the quality of life for people with acromegaly. So we don't have enough, number one, endocrinologists. We don't have enough people trained to identify endocrine disorders, which means those people that are working in primary care. And we try to teach them to recognize the disorders like acromegaly too late. So we want to be able to try to identify those things much earlier.
For patients trying to identify an endocrinologist, what questions should every pituitary patient or every patient with acromegaly ask their endocrinologist?
I think the first thing is if you have a pituitary tumor, how many patients do you have that you've treated that have acromegaly or Cushing's disease or whatever that pituitary dysfunction happens to be? That's a big question because, again, if you are, they may be very good as a provider, but they also may need to have some guidance from a center of excellence and be able to consult with that center to make sure they've got the right treatment, the right doses. Now we have lots of options and we have more medications that we can use together. And so I think that's the important part is how many do you treat? And then who do you communicate with? Who is your closest center of excellence? If you're talking about surgery, who's the neurosurgeon? Because that's the next big issue. A neurosurgeon that does 1 or 2 pituitary surgeries a year is not who you want to collaborate with, right? And so what you need is somebody who does 100 or has done 100 of these within a short period of time, okay? So that they know what they're looking for, and then they can remove that tumor successfully at first attempt.
You briefly touched on medications. What's the difference between octreotide and lanreotide and the newer options? Can you detail that for me?
And octreotide was one of the first, actually, cabergoline was probably one of the first things that was used. But it's not been shown to be very effective long-term for many people unless you've got a very small increment in your level. But again, octreotide was the next biggest agent, and it was first of all administered daily by a shot, right? And now we have monthly injections. So we've improved in that regard, and we're starting to see the development of oral medications. So the difference between the oral medications and things like octreotide is a big molecule. And so itself, unless it's modified in some way, it's too big to be able to take orally. And so if you have something that's in conjunction with that, and some of the medications now have a different way of packaging that molecule so that it can be absorbed then through the gut. The other forms of medication, there is no one medication that's 100% effective for everybody. And so do we know why yet? We know some of the factors, but we don't know them all. So it's part of the receptors that we have in our body and how well that particular medication then blocks those receptors or stops the high level of GH being produced from the pituitary. And it's a little different for everybody. And so what may work for you doesn't necessarily work as well for somebody else. So, or the medication may not take your level down to the lowest level, so below that 1.0, and you may need to add another medication to bring that level down just a little bit further and improve your symptoms and your concomitant issues a little bit better.
So dual therapy is what you're talking about, more or less, correct?
Yeah, and sometimes it's maybe 3 agents. But yes, we're doing more and more. We're able to add different therapies so that we can then get better, what we call, so it's going to work better for that individual.
Are there any new developments in pituitary care that you're excited about now?
Well, I think the movement towards decreasing the frequency of medication is really important, and also the availability of oral medications. That I think is extremely exciting in that people want to live a normal life and not be tied to coming in every month to a hospital or an infusion center for an injection. If you have an oral medication that you take once a day, it's just like having high blood pressure. You take your medication, it controls your disease, it controls your symptomatology. I think that prospect is very exciting, and I think we're moving very much in that direction.
What does good care for a patient, in your eyes, look like?
I think one word, collaboration. So it's a plan and it's an agreement between a provider who's the consultant and the patient who has to live the life. And so the patient, and I tell my patients, there's like 8,000 something hours in a year, right? And you have to manage your care 7,999 hours of that, right? Because you do not get very much consultative time. And so, number one, make the best of it. Number two, have a plan that can work for you, that that you are comfortable with, that you know what the modification kind of parameters are, and you work with your consultant provider to be able to achieve that. So that to me is good care. It's collaborative.
And in giving good care, without going into details, do you have any patients that you treated in the past that you can say were very hard to treat, that it took quite a while or very hard to get them controlled? And what was the process of that?
Yeah, and I agree with you, and it is a process. There are patients that are very difficult. It's kind of like the bell curve, right? There's always people on both ends. There's people that do extremely well. There are people that are really struggling in the middle, and there are people that really, really, really struggle at the bottom end. Those people, who knows what the issue is? For whatever reason, they're resistant to the treatment, and we don't exactly know what that looks like at this point in time. We know that there are some markers that we have to consider in the tumor itself, and there's probably a lot more that we'll be discovering over time. But if you've got a patient that really is struggling, I think it's forming some kind of a realistic plan that they can live with, and knowing, okay, where we're going with that plan, and that it's something that they can adhere to, because that's part of that process. Working that collaboration, I think, is really important, and it's really hard. It's hard on both the provider and it's hard on the patient when you can't make the kind of progress that you think you really need to make. And unfortunately, we will always see those patients.
Understood. Of course, I know several people that I'm in contact with currently, and even over the years, who are at a point where they want to give up. It just seems like nothing's working for them. And part of the reason I do this is to encourage them in particular, uplift their spirits. That's what's most important. And having a doctor like yourself who understands definitely helps.
Right.
With that being said, what words of encouragement would you have for someone newly diagnosed with acromegaly?
I think the newly diagnosed patients, one of my concerns is that they feel like once we take the tumor out, that they're cured. So I think it's discouraging, but it's also encouraging. This is like keeping hypertension or keeping blood pressure controlled. We have to keep working at it. We have to keep making sure that this is controlled so we can take out the major offender, and we have a good chance still of being able to cure you, which is, we call that remission in preference to cure, because we need to continue to follow you to make sure that you're healthy for the rest of your life. But it's achievable. You can live with high blood pressure. You can live with acromegaly. But your support, like you were talking about, is really, really essential. We know that people that have support generically across any kind of medical disorder have better outcomes.
There a correlation with that in acromegaly?
There are some patients that will have tumors, pituitary tumors, and have acromegaly, and can have like pancreatic tumors, etc., as well. So when we look for a patient that has a pituitary tumor, we also look to see, is there anything in your thyroid? Is there anything pancreatic? And so what's the family history? There are a number of factors involved in that. What other symptoms do you have that we need to consider? If there's like parathyroid issues as well as a pituitary tumor, then we start to get a little bit more concerned about this potentially being some kind of a genetic type disorder, whether it's heritable or not.
Sounds good. With that being said, Chris, it's been a pleasure having you today. I want to thank you for your time. I want to thank you for joining me. And I want to thank you for talking acromegaly with Tony. It's been an absolute pleasure having you today.
My pleasure. Thank you, Tony. I appreciate it.
I want to thank you for what you've done over the decades, for your dedication to pituitary and endocrine patients throughout clinical care, research, education, and leadership. You truly have made a difference around the world. Conversations like this remind us that behind every diagnosis, there is a person who deserves informed care, compassion, and hope. And thanks to professionals like you, that standard continues to rise. To everyone listening. Stay informed, stay empowered, and never stop advocating for better health. If you found interest in this episode, please drop a comment, share it, like it, and hit that subscribe button. You can also follow me on all my social media platforms. Thank you for watching.
Thank you. Thanks for the patience teaching me.